Hey everyone, smoking and P.A.D. It's a tough topic, but Dr. Johnston is ready to tackle it. We have a great live studio audience who's here, and they're all fighting with everything they have to try and just abstain from taking just one more puff. Dr. Johnston, when someone comes into your office and they say they smoke, what is that first thing that goes through your mind? And then next that comes through your mouth?
Well, I want to remind everybody that nicotine is an addiction, and it's like alcoholism, it's like drug addiction. That's a disease. So it is a disease that goes on the problem list, and it is not inherently a moral failing, but it is a serious concern when it comes to our ability to be successful in saving lives and saving legs in patients with PAD. So, what I want to know is, are patients open to a conversation about smoking cessation, about cutting down because that helps? And where are we in terms of readiness to quit?
Mhm. And what is their confidence that they can do it? What is their confidence level in terms of what can they do now? Do you, on a scale of 1 to 10, do you have confidence that you can quit cold turkey? Okay, that's a level 3. Do you have confidence that you can go from a pack a day to a half a pack a day? Confidence might go up to 6. And what do you think about that type of conversation and process by which you can determine the next, the best course of action for helping that patient?
That's such an important consideration as we talk about readiness for change. And this is all sort of part and
Mhm.
parcel of motivational interviewing, which is something that many surgeons, and sometimes myself included, will not have time to delve deeply into at a clinic visit to talk about ultrasound results or preoperative planning and what needs to happen to take the next step with respect
Yeah.
to the blood vessel blockage. But it's a huge component of people's ability to be successful, to be brave enough to try to quit again, because so many of these patients, this is not the first time, it's not the 10th time they've tried to quit. They have tried over and over and over again. Every time it feels harder and less likely to succeed. And I remind my patients that all of addiction is about relapse and recovery, and it's expected. It is never the expectation that somebody is going to quit forever and never smoke again or never drink again, right? This is why the 12-step program talks about it at one day at a time.
Yeah.
And when you relapse, you start over, and there's no judgment about that. It is, at least from the community, right? Everybody will judge themselves, but it's okay. One day is one day.
And that's what I tell them. You can't, judgment is a really big issue that ends to relapse. And it's not judgment from others. Even with our group, we don't pass judgment on someone. Um, but I know that Pam and Marianne and Wanda, one of the biggest issues I think that they've explained to me, like over the weekend, where we were really fighting hard because several had procedures last week, and the doctor said, you better quit. Just one more puff and that could cause damage. And so they're doing really well. But when they went back and they had maybe a couple puffs, then they're starting to kick themselves. And then that anxiety kicks in, and then stress kicks in, and then they're having another puff and another puff because of that. Talk about the importance of literally, you sometimes do take 2 steps back and 1 step forward, and it's okay.
This is the importance of community in this process, and having friends or sponsors or peers or whoever, because when that shame spiral starts in our own brain, it's nearly impossible to stop it yourself.
Yep.
And it does lead to continuing the behavior, because why would I bother? Why would I bother quitting? I've already relapsed. What's another cigarette? What's another pack? What's another month? But when you can call somebody and they say, no, it's okay, right? 2 puffs is not the end of the world. It is better than 2 cigarettes. That's better than 2 packs. It's better than the next 2 months.
Yeah.
And you can do this. And I believe in you, and you haven't failed. And it's just this reminder that our brain lies to us. Our brain tells us things all the time, and many of them are not true, but it's hard to get out of that by yourself. And I don't think that humans as organisms were ever intended to do life by ourselves, but having that supportive community of peers who are doing this with you, who need that themselves. It's so helpful in every facet of behavior change, whether that is sticking to a different way of eating, whether that is not drinking, whether that is not smoking. I've seen this work over and over again in people who have those community resources and those peers who are doing this with them.
Mm-hmm. Can we go back to the very beginning of you pick up the cigarette, you take that puff. Where does that puff go?
Yeah, it's a poison that goes everywhere, and it will attach to the red blood cells and prevent oxygen from getting where it needs to go. It gets into the lungs, obviously, and can cause damage there. It damages the lining of the blood vessels throughout the whole body, and it is a devastating thing. And patients know this. And what I'll say about it is, creating fear has really never been an effective way to get people to change behavior. That said, I do think it's important for people to understand that that's what happens, but I don't think that that's what's going to cause somebody to stop smoking. Their why has to be bigger than that, and it has to be bigger than the fear of me shaking my finger at somebody in the office or in the emergency department, which I'll be honest, I've absolutely done, and I'm not proud of that, but it goes without saying that that's probably not what's going to be the thing that causes somebody to really dig deep and quit.
I'm curious if any of the folks in our group with P.A.D. want to speak up and talk to what she just said, because you would think that the fear of losing your legs would be enough to have you put that down. And for some, it is. We've had several patients, but that doesn't mean that everyone can do it, and it doesn't mean you're less than anyone else. It just means everyone is different and has different experiences. I'm curious, even, Pam or Marianne or Wanda or Douglas, if you can explain, why is fear when it comes to smoking not enough to actually get you to quit?
Well, I think our
Douglas?
emotions come over our reasoning. We get that urge and we want to satisfy that urge, and we forget to look at our list of reminders of all the important reasons to quit.
Yeah. And Douglas says, Douglas, do you want to unmute? I can't read what you just wrote. Yeah, it says sometimes an addiction. Go ahead.
As an addiction specialist for 30 years, I also know in recovery, I also know sometimes the addiction in the stages we're in addiction can override that fear.
Yeah.
And we know the consequences, but the addiction sometimes is stronger. And that depends on where we are in the stages of that addiction, where we are in the stages of wanting to quit that bad. You can bring them to the water, but you can't make them drink, right?
Mm-hmm.
And Dr. Johnston said that. So that is something we need to be aware of in the addiction stages, where we are and what are you willing to do to make that change?
Yeah, I think that's so important. I'm not sure if Marianne wants to jump in with what you think as well.
Well, I do agree with it, and I like how she said earlier about the brain, because that's affecting me right at the moment.
Mm-hmm.
And my thought process is completely off. But I have noticed in the past, even with trying to stop smoking, if I am here at my own house by myself, I smoke more. If I go take a trip, I can leave the cigarettes home and be gone for 10 days and not miss them at all. So it just a mental thought process and habit. And I did smoke one Friday before I had a meltdown with Kym, and I have not had one since. So
good for you. I'm so proud of you. But also, you were in debilitating reperfusion pain. And Dr. Johnston, I was texting with her doctor who was on a plane, her vascular surgeon
Yep.
out of Texas on a plane, and he's like, they didn't give her any meds. And I said, no. And he's let me take care of that
Wow.
now. So
So,
the poor
yeah,
thing was
whatever's going on
suffering.
today is up on the right side of my head, and it's affecting my brain and my hearing and my vision. So I apologize. I'm kind of all over the board right at the moment.
Okay, we might have to get you checked, but at least right now you're not smoking.
I'm a
And
zero.
hopefully, right? And we always hear this a lot, Dr. Johnston. A lot of it is that you're at home, you're lonely, you're bored. I mean, not as if you don't have things to do, but it's just that's always a tough space. And I know that that's something that Wanda has dealt with as well. And I know that Douglas said that the same thing at times, but maybe if you have any questions for her that you think could help you, just hearing her say something about smoking and P.A.D. that you think might make the difference, please, we want you to jump in and ask questions. But post-procedure, especially, Dr. Johnston, we want to walk the patients through what happens with just one more puff. The way I explained it to them was there's trauma, right? When you go in, every time you go in to revascularize, open up those arteries, you add a little trauma, and your body needs that extra oxygen to heal.
Absolutely, Kym. The other thing is when we traumatize the vessels through these procedures that we do, or we put in a stent that's a foreign body, the body's clotting system is ever so slightly more active. And the addition of tobacco and nicotine will actually exacerbate or make that worse and make it even more likely to clot. The vascular endothelium, or the lining of the blood vessel, becomes more reactive. It spasms down with more nicotine. It's a vasoconstrictor, and so it gets tight. And that means that all of those repairs that are super fresh and a little bit likely to clot may be even more likely to clot and suddenly. And that is obviously a catastrophe if that happens. And so it is our hope that people can abstain in that post-procedure period to try to minimize the likelihood of that happening.
And it's interesting, we have Marie here, and Marie's, she's a long time, member of our network, and we've gone through a lot together. And before meeting us, I think she had more than 60 procedures before coming to us, and we were able to literally space those out. Even I think she's gone, at one point she went more than 2 years between having procedures. And they had never talked to her about and made sure that she didn't stop smoking. And I think that was the same thing with Douglas. Douglas, you had that same situation, not once. After you had stents, then an aortobifemoral bypass, and then an axillary bifemoral bypass. And every one of those failed within 6 months of one another. And in less than 2 years, they were telling you no option, but not once did they tell you to stop smoking.
I did not hear that until I got with that doctor in Louisiana, and that was the first time, 2 years. And like you say, I had all those bypasses done and they all failed. And then I developed a heart condition, and they still, when I ended up in Houston with my heart, they stopped smoking, but then that was it. And that's where we have to come in on Monday night with our group to convince people what you're talking about and the importance of having to stop smoking now.
Yeah. Dr. Johnston, do you have any patient stories to share with us with tips and tricks on how they were able to either quit cold turkey, or methods, even if they're unconventional, that they used in order to kick the habit?
I don't have any unconventional methods. I have had 2 patients who quit cold turkey when they had mini strokes and then needed procedures from me to clear out the blockage in arteries in their neck. And they were in the hospital for a few days, and we spent, some of that recovery time talking about the role of smoking. One of them actually has a partner who still smokes in the house, and that's been a remarkable feat for her to be able to quit while her husband still smokes. And but she's so proud of having done that. And the thing that she told me was, I didn't realize that I couldn't smell or taste anything anymore. But now that I've quit smoking, all of a sudden food is amazing and I'm cooking much better because now I can taste things and like the world is just more enjoyable. I smell flowers, I smell baked things in the bakery. Like she was just blown away by how much more sensory enjoyment she got out of life after she quit smoking and how much more easily she could breathe. And all of these things that I never even thought to offer her as reasons that she might want to stop smoking. She just experienced that on her own, and she's done remarkably well. I also have patients who have told me flat out that they are not ready to quit and they continue to smoke. And I think, why aren't doctors talking to patients about this? Like, this is the question that I have. And I think if I had to guess, and I won't speak for all of my colleagues, I can't, but I would say, one, people might assume that it's self-evident, right? That everybody should know they should stop smoking. So why should the surgeon have to say so? I think the second thing that might be happening is that doctors don't know how to offer support. So they can say, well, you should quit smoking, but I don't know how to help. So I don't want to prescribe Chantix or your nicotine patches or whatever. I don't know how to do that. I don't know how to help. I don't know where to send you to get a peer group or to get counseling for this. And so they just don't bring it up. And all of that is not the best care for our patients. But I just, why wouldn't somebody mention it? And those are the options that I can think of.
Yeah, we need a care protocol, that it's like a little package that said, here are all the resources, and just every single P.A.D. patient gets that same, set of resources that can help them. Yeah, Douglas, go ahead.
Yeah, but Dr. Johnston, I think that's the thing that we struggle sometimes with on Monday nights, because we have individuals in our group that had strokes and said, "That's it, I'm done." But some of us can be very hard-headed. Some of them are stubborn. And how do we get them from one stage to the next stage to the next stage as individuals, because they're all individuals and they all deal with different triggers and strategies, and trying to get them from one stage to another without it lasting a year or 2 years before they actually quit.
You said it best, I think, Douglas. Like, you can lead horses to water, and you cannot make them change. You cannot give them a why that will force them to change their behavior. All you can do is show them a community that will support them and show them that it is possible to do this. And there are people who have had success, and to continue to be supportive without shame, right? I think the other thing, the third reason maybe doctors don't bring this up is that they're afraid to be, to shame patients. They don't want to keep bringing it up because they don't want patients to feel badly that they're still smoking. And there is an art to this, to, engage in this conversation that says, are you still smoking? How is that going? Are you ready to quit? And if the answer is no, then you say, I get it. It's okay. I would be a bad doctor if I didn't tell you that it's likely to harm you in some way, right? And that's it, right? That's all I have to say. I don't shake my finger. I don't say what a bad person you are. I just say, when you're ready, I am here. It has consequences, and I'll do my best. But
so there is that progress, not perfection. Because
Right.
if you look at where Wanda is and Mary Ann, where they were when they started and where they are now, it's night and day from where they got into the group and where they are now. So sometimes it takes some of us a little bit longer to get that light bulb moment. Oh, I need to quit.
Yeah.
Yeah. Dr. Johnston, hi, I'm Wanda.
Hi, Wanda.
I don't know if I'm gonna be able to talk. This is real hard. I've smoked for 50 years. We'll try to get this out.
We're here for you. You're doing great.
In 2017, I had a femoral endarterectomy. I also had a teenage kid, and I was also very, I don't know how to put it, other than the only way to survive it was to be a smart aleck. And I knew everything, even though I knew the doctor was right. But I didn't have time to be sick. And I said, and I kept smoking. So anyway, the bottom line is he did say to me, have you tried any nicotine replacement therapies? You just mentioned that. So, I mean, there aren't any. I mean, there's like on Amazon, there's a non-nicotine, no tobacco. I don't know if I should say the name, if I'm allowed to say the name. I'll be advertising for it. But anyway, you can't do the patches that has nicotine in it. So,
Yeah, we had a doctor that came on, Dr. Ferrugia, and he said he doesn't want any nicotine in your bloodstream at all. And he said
water
it can actually cause, he said it's not a long-term solution. It's something that is a transitional product. And the goal is to have nothing in your bloodstream, because he was going into details about what even nicotine, it raises blood pressure, et cetera, et cetera. So he said the goal is to just completely abstain 100%.
And I agree with that as a goal. And I will also echo Doug's point again, which is progress, not perfection, because so much of this is behavioral. We have to get away from the like oral fixation of the cigarette and of the, I have one after dinner every night, and there's a behavioral component to this that is cued by, like Marianne said, when I'm in my house, this is where I smoke, and I smoke a lot here. I can go away for 10 days and not miss it. But these are the behavioral cues. And sometimes the nicotine replacement, whether that's a gum or a patch, will help that part get less pervasive and less strong in our brains. And then we can work on actually getting rid of the physical substance that is addicting and that is harmful. But the patches all have a dose, so you can de-escalate them slowly. And then there are some non-nicotine options, right? Chantix is an option as a pill, which is prescription, and some people have side effects or don't enjoy that experience. But nevertheless, there are some other pharmacologic options that exist that are non-nicotine, and will accept progress, and we will celebrate progress, because that is one more step toward abstinence and towards getting nicotine free. But I don't think it's realistic to expect people to do that cold turkey all the time.
There comes a time, though, where I know I've been in different cath labs across the globe, and I've even flown to Utrecht, and it was literally a 2-night trip, and we flew in, and we were going to cover a brand new technology being used, and the doctor did the timeout, and he suddenly stopped, and he started sniffing. He says, "Wait a minute, Mr. When was your last cigarette?" He's like, "Well, I had one this morning." And he stopped and he sent the patient. He's like, "You're fired." And I literally could not believe it. Just, "You're fired, not treating you, goodbye." Sent him out of the room. And I asked him, I said, you couldn't treat him and then just make sure that he says, "No, because it completely defeats the purpose of me doing it. The moment that I open him up, he's going to plug back up. He's going to go home." And he's like, "You need to have 2 weeks, between the last cigarette and the procedure, and make sure," he said, "hopefully they won't start again, but I need at least 2 to 3 weeks post procedure to make sure that it's not going to interfere and we don't continue with the revolving door of treatments due to the increased clotting activity." So I'm just curious, from your standpoint, because I know that we do have several of our friends with P.A.D. here who do smoke and had these procedures last week, I think I mentioned earlier. And in every case, the doctors are on their last options.
Yeah. This comes down, in my mind, in my practice. Again, I won't speak for all of my colleagues. There's a real distinction here between P.A.D. with claudication, pain with walking, which is non-limb threatening, versus P.A.D. with limb-threatening ischemia, meaning ischemic rest pain, like nocturnal rest pain in the feet at night, or tissue loss, wounds, ulcers, gangrene. Once we're in limb-threatening ischemia, all bets are off, and we will, I think, we will proceed with whatever interventions are necessary to try to save a leg, with the understanding that our odds of success are lower, just to be honest and blunt, in a patient who is still smoking. That usually does not come as a surprise to those patients. There is a gray zone. There is short distance claudication. There is atypical rest pain. For those patients, if there is a chance that we can get them 2 to 3 weeks of nicotine abstinence prior to a procedure, that's a great idea. And for my patients with claudication, I do not offer procedures for patients who are still actively smoking because it's not limb threatening. And we have to not get into a situation where it becomes limb threatening, and that is the risk. So I don't think it's medically appropriate in patients who have stable claudication to offer those procedures. Now, will I fire the patient? No. That patient will come back and see me, and we will keep talking about it, and we will keep working on walking, and we will keep trying medications to see what we can do to help their symptoms, improve their walking distance, walk, and see about how we're going to manage the addiction, because those are all part and parcel of treating the P.A.D. But I don't think it's appropriate to offer patients with stable claudication invasive procedures while they are still smoking.
Yeah, I think it's so important. And I'm just curious, anyone wanted to, I'm quick to ask questions. Douglas, go ahead.
Yeah, I think you said something a minute ago that's very important. And it's the distinction between we hearing how bad it is for us, but the behavior. Addiction is a habit. You do something over and over and over so many years, it becomes a habit. I get in the truck, the first thing my brain thinks about is lighting a cigarette. I've been doing that for 30, 40, 50 years. So every time I get in the truck, that's the first thing I think about. Until I change that behavior, that thinking process it's still there, but I have to be able to change that behavior. Correct?
Yep, absolutely.
And Mike is here. Mike actually had quit cold turkey. I know Mike has a question he wants to ask. His mom was an amputee. He shared his story and her story, and he walked out of the appointment and just said, okay, I'm done and no more. And he's done incredible over the last year. Mike, what's your question?
Hi, Doctor. Hi, everyone, by the way. Sorry, excuse me. I just wanted to know, I've seen a lot of people in the group that have gone from smoking cigarettes to smoking like nicotine vape pens, and then they've reduced the nicotine in the vape pen and gone to a non-nicotine vape pen. Is the non-nicotine vape pen, is that still bad for you, even with it having no nicotine in? I'm just curious. Like Kym said, I've not smoked for over a year myself, so I'm not likely to go back to it. But I'm just curious about these things. I wonder if a non-nicotine vape pen is good to ease the cravings.
Again, I think if it helps continue abstinence from nicotine, I'm not going to argue with it. I do have some concerns. There have been some case reports of lung injury from inhaled glass particles from the vape pens and some other things that are not related to the blood vessels specifically. But, it's probably not the safest thing in the world. But honestly, we inhale pollution depending on where we live. And there, all that to say, when we're talking about people who are in recovery from smoking addiction, I will take what I can get. And if that is a non-nicotine vape pen to help with that behavioral, need to have something in your hand or something in your mouth, then I get it. And, would it be better to be abstinent? Sure. But I feel that way about, like Diet Coke too, right? If people were drinking sugary beverages and like Diet Coke was the thing that got them off, is it the perfect solution? No. Is it better than regular Coca-Cola? Probably yes. So, it's the lesser evil, and we'll take it.
Yeah.
That's
sorry.
a
And
good example.
would that go the same as like, a THC vape pen? Do you know anything about THC vape pens?
Yeah, the THC thing is becoming an interesting story. We don't have as much data yet, but there are some signals that it is also harmful to the cardiovascular system.
Yeah.
Okay.
And so I have some concerns, at least about, marijuana, whether that's specific to marijuana, whether that's THC, whether I don't really know exactly where we are with that. And it's an we're early because we just don't have as much data, but I have some concerns about that.
Yeah, we had a
Okay.
cardiologist on who also expressed those same concerns. I guess there was a recent study he had mentioned that came out that showed a strong correlation between that and, of course, cardiovascular risk. But there are a lot of people that are wondering about marijuana, and you mentioned that as well, whether it's vaping or even smoking. And what we always say is, as soon as you burn something and it goes into your lungs, like it's toxic, right? It's a poison. It's burning of material. And Science Direct had come out with a study, and I've said this a few times, they feel like a broken record, but it was just a couple years ago that showed an increase in the number of 18 to 27-year-olds showing up in emergency rooms presenting an advanced stage P.A.D. And two of the attributing factors include diabetes and marijuana smoking. And so all of these stories that we're seeing in the past few weeks where the media is praising the younger generation for not drinking, well, what are they doing? They're smoking marijuana. And is that any better?
Right.
Douglas?
So here's a good question. Have you had a patient that you started working on and they quit smoking and started walk? Have you thought to yourself, wow, they quit smoking and 2 months later you can see collaterals. You can see the P.A.D. issue kind of retard itself, per se, because they quit, and how big a difference that makes. And does it happen automatically? We know 3 days later it starts to get out of our system, but how does that affect P.A.D. when we do quit, and how fast will that work?
You start to see some improvement in the vessels you already have, as you say, almost right away. And this is why, that physician said, I want 2 weeks of abstinence, even leading up to the procedure, because it means that the vessels downstream are less likely to be in spasm or to constrict and get super narrowed and mess up the blood flow. The formation of new collaterals, that's driven by the walk. And it comes together. And I have seen people who've had remarkable success with both of those things in combination, but it takes months, I think. You may start noticing a little improvement in how the legs feel right away, but it's subtle, right? It's 2 more steps than yesterday, and you may not even notice, but over time, it does compound, and it does allow those collaterals to form more robustly. And it is absolutely part of, a successful non-operative strategy for managing that pain with walking.
Yeah, we were told at one point that if you're walking while you're smoking, it's great. I had a patient, Dr. Johnston, who had we show up for appointments and take notes for patients during their consults with the doctor. And one in Texas, the doctor asks the patient, so have you been walking? And she says, oh yeah, of course. Kym makes me walk, and I walk. I have a cigarette in my hand, but I walk. I was like, oh no. Oh no. And he's like, okay, well, that's a start. Next is the cigarette. But what he told her in that moment, he said, but just know that when you're walking, that the cigarette can kind of counteract what you're doing with your collaterals. It can basically, plug up those collaterals. So, and can you talk a little bit about that? Because those are really small vessels.
Yeah, it's that idea that these are tiny vessels. They are much smaller than the ones that we're treating that have names. And you can think of it, it's sort of the difference between looking at a big tree branch versus looking at all the tiny little itty bitty twigs that make a bird's nest, right? That's what could collaterals look like. They are these tiny little itty bitty vessels, and there's many of them, but they're small. And those small vessels are very prone to going away or clotting off if they spasm or constrict down suddenly. And that is what the nicotine does tend to provoke, is that spasm. So and clotting. So we get, it's sort of a contradictory or opposing effect, where the walk is trying to build those collaterals, but they may not survive if the nicotine is causing these fragile new small tiny vessels to suddenly spasm and clot off.
You bring up a really good point as we start tapering towards the end here. I know you're on call and have to get back to clinic, but Berger's disease. So we've had several patients end up with what the doctors described as a smoking driven acute limb ischemia. And with their toes and everything, and I don't know if it's acute, but critical limb ischemia, the gangrene and such. And the moment they stopped smoking, things started improving for these patients.
Yeah.
So talk about the difference between Berger's and P.A.D.
Berger's is a type of P.A.D., but it typically affects the tiniest blood vessels in the hands and the feet. And it's very, very difficult to manage surgically because there's not really a target most of the time for a bypass. And then the outflow, we talked about this in a recent episode, right? The ability of blood to continue flowing past the into the capillary beds. If those capillary beds are all constricted down because of active nicotine, then the whole system just stops and backs up, and the bypass will fail. So Berger's is a very challenging disease, and truly smoking cessation is the mainstay of treatment. We will do what we can if there is an area of narrowing or blockage that we can fix, but it is really the damage and death of the tiniest vessels in the hands and feet. And often there is not a great option for bypass or anything endovascular. And if it presents acutely, it's often that there was some collateral that was feeding things. But usually you'll see that if it's the hand, that the radial and the ulnar arteries sort of peter out in the mid forearm and never really come back. And so there was probably some collateral branch from the interosseous or something that was feeding the rest of the hand, and that went down. But even if it's just chronic limb threatening and it didn't happen acutely, it's a really devastating, tough disease.
Yeah. So I want to just open it up as we close out here. If anyone in our live studio audience wants to comment, any improvement in understanding, final thoughts, before we close out, any questions before we close out, anything that will help you to take that next step? Everyone satisfied? Marianne has something she wants to, or you don't. I see you're typing something.
No, sorry. I heard that we're about to wrap it up. My battery's getting low. So if I went away, that's what the issue is. But I did find I have enjoyed the conversation today, but I have found with our no smoking group and the challenge we had by the other doctor is kind of what has motivated me. It wasn't a reprimand. It wasn't, you have to do this. It was like, here's a challenge.
Oh, good point.
Can you participate, and do you want to do it? And so I liked the challenge part because it put the responsibility back on me.
Oh, that's interesting. Yeah, creating that challenge. So he said in 4 days, Dr. Johnston, he said he wants you, it's like having a ruck pack. He wants you made of water bottles. Oh, and you have that. So get a whole bunch.
It's a straw, but I carry the tip so it feels like a cigarette on a straw, and I carry it in my water bottle so that I'm not holding the water bottle to my mouth for 4 minutes.
So what it is that he has the extremes. So everybody modified it for something that would work for them. And I like what Marianne did in terms of her modification, but it started out, how many cigarettes do you smoke a day? Okay. So get a whole bunch of those little water bottles from Costco that I think are like 8 ounces, fill a backpack, and this is going to take you 4 days. So you're going to wear that bag of that many water bottles on your bag for 4 days until you really have no urge at all. And the idea is every single time you have a craving, he says cravings are typically last 3 minutes. For 3 minutes, you're going to suck on that water bottle and you're not going to remove that water bottle from your mouth until your clock says 3 minutes are up, and that craving should go away. But to take it a step further, Marianne came up with the idea to actually use a straw because it's kind of like a cigarette and she could chew on it. And she said keeping that to her lips was really effective. She could chew, she could do little sucks of the water, and it really helped, right, Marianne? There she is. She's doing it in the live studio
demo.
audience right now. Yeah. But it really
that's
helps because
amazing.
you have something in your fingers. And Dr. Ferrugia was saying, he's like, you're going to be cursing my name by the end of day 2. Your back's going to hurt. You're going to be stressed out. But he's like, I promise by day 4, you're going to say, screw this whole thing. I get it. I now have a new lease on life, and I'm not going to smoke. So.
And we checked in with each other as this was going on. So it wasn't an isolated type of deal. It was like each of us were sponsoring each other.
Yeah.
That's wonderful. I'm so proud of you guys. I just, on behalf of the doctors, we are on your side. We are on your team. We want you to succeed. And we are so proud of every time you think about it and don't do it. And it's okay to relapse. It's okay to struggle. But I am really proud of all of you for being here and showing up and doing this really, really hard work. Your job is harder than mine, and you're doing great.
Thanks for coming on. I appreciate it too. And, it's hard going cold turkey. I mean, that's why I ask about the patches.
Yeah.
So.
But you're here, you
Whatever
show
it
up every
takes.
week and you're trying, right? And you are working to become the best partner in your care. And that's so much more than so many out there. But if others want to become a better partner in their care and need the support, want to join our group, we actually have a really good time. There's no judgment, and everyone quits at their own pace. Some are cold turkey, and it's great, such as Mike, who's here in our live studio audience. But others do take a little bit of extra time. But we're here on this journey with you, step by step by step, even if it's 1 step forward, 2 steps back. Join our smoking cessation group. Go to thewaytomyheart.org/quit-smoking. And don't forget to like this video and subscribe to our channel for more great content like this. But also, make sure to navigate over to Dr. Lily Johnston's channel because it's amazing. Even greater content as well. And her channel is youtube.com/the@ Lily Johnston MD. Thanks everyone for joining us. And thank you, Dr. Johnston, for jumping in and hosting this wonderful, candid conversation.
Thanks to you, Kym, and to your wonderful smoking cessation group. You guys are amazing. Keep it up.